Um, so I was told and informed basically to give a challenging case, and definitely I have a case that I've been facing where I had first came into interview with back in May 2020. So the case goes along as a 65-year-old lady of European descent who was diagnosed with neuroendocrine tumor 5 years ago, located at the duodenum, which she had it resected back in 2016. She presented to clinic during the early COVID-19 pandemic for follow-up in May 2020. At that time, she didn't have any scans since 2018. There was a breakage in follow-up through all the 2019 year. She didn't have any scans. The past medical history of her was significant for diabetes and overweight. Nothing else basic in her past medical history. Family history is quite significant for cancers. Her father died of leukemia. She had a sister who died of breast cancer at the age of 60, another brother who died of sarcoma at the age of 45, and she was not allergic to any medications, thankfully. So which of the following is important in this case, even before interviewing the patient? Is it to go over pathology, restaging, or continue just clinical surveillance after you see the patient? So definitely we all need to know the basic pathology and restaging that she had. So before she came into clinic, we definitely ordered CT scans, and that's the main pathology that she had on the right-hand side. As you can see here, it's a terminal ileum, resected low-grade neuroendocrine tumor, T3N1, and most importantly, the mitotic rate was less than 1 with a KI 67 positive staining of less than 1%. And she had one mesenteric lymph node that was positive, or 2 out of 5, sorry, that was positive, and they all were resected. And that's the pathology was based in 2016. So that's the restaging that she had back in 2018, last time when she presented to my previous colleague. And she didn't have any residual diseases or masses at that time, as per the report. So Octreotide scan was done in 2018. Again, there were no lesions at that time before there was a break of follow-up. So we definitely reordered a CT scans of the chest, abdomen, pelvis in 2020 when I had met her again in May 2020. She did not explain any symptoms whatsoever from a clinical point of view, so it was just to follow up. And that's the CT chest, which didn't show any interthoracic lesions. However, I'd like to draw your attention to the lesion that is located in the right breast, as you can see here very clearly on. So it was unclear, and it required further workup with mammogram and ultrasounds accordingly. So that's a restaging of that abdomen pelvis, which showed multiple lesions in the liver, the largest of which was located in segment 7, followed by segment 2, and there were a couple small liver lesions as well that were a bit deeper. So based on the CT scan, it was recommended to get an MRI abdomen, which we got, and showed that the largest lesion, as you can see here in segment 7, measuring about 1.6 times 1.8 centimeter, and another lesion in segment 2, which was about 1 centimeter. And again, they notified the incidental notice of the enhancing nodule within the right breast mass of 1.7 centimeter. So clinically, when she came again back in July of 2020, after the CT scans were done, during her visit, she was explaining increased symptoms of flushing, diarrhea up to 5 times per day, and this was not associated with any shortness of breath or wheezing, thankfully, at that time. So what would you do next? Would you get 24-hour urine 5-hydroxyindolic acetic acid, echo, or would you get the urine test, echo, Octreotide scan, glucagon levels, or C-peptide levels? So as you can all imagine, we definitely had went for the choice C, which is the urine test of the 24-hour urine 5-HIAA, followed by echo and Octreotide scan. So the echo showed a left ventricular ejection fraction of 45%. Most importantly, there were no typical features of carcinoid heart, and this is exactly the main reason for me to do the echo, just to make sure that we're not missing that, as most of these patients would succumb to their death because of carcinoid heart. The 24-hour urine was elevated of about 18. The Octreotide scan was very interesting. So the Octreotide scan showed segment 7 uptake at the right hepatic lobe, which is corresponding to the largest lesion, as you can imagine, and there was low-grade focal uptake in segment 2 of the left hepatic lobe, which is corresponding to 1.1 centimeter in segment 2. And there were other lesions, but they were not as readily avid based on the Octreotide scan because of their small size. And as you can see here, the conclusion, which is very important to know, is that there were octreotide avid hepatic metastases as described, but there were no octreotide avid extrahepatic lesions. That's very important. So what to do now? Would you start octreotide immediately, go for a biopsy of liver lesion, or would you go for straight up PPRT or start with everolimus immediately? So as you can well imagine, we definitely started on octreotide even before we went to the biopsy, based on the clinical symptoms that she presented and with from the get-go. However, there was still an ongoing concerns about the liver lesions and the fact that most likely would represent the similar lesions that she had before, or there has been some changes from the previous biology versus metastatic from another primary. So a liver biopsy was being planned. We've taken all precautions. She already had been started on octreotide therapy a couple of months before. She started first at 30 milligrams IM, Q4 weeks of octreotide LAR, but unfortunately her symptoms did not go away completely. So we increased the dose or decreased the frequency at first to every 3 weeks. And she had significant improvement in her diarrhea and flushing, but it did not go away. So we increased the dose and kept the frequency as it is, and there were complete resolution of all of her symptoms after we've done that. So we've taken all the precautions that you usually should take with giving octreotide IV, and keep her on a drip before you do any biopsies for these patients to avoid carcinoid crisis. So the liver biopsy was taken successfully, and that showed a focus of pseudoproliferation consistent with metastatic disease from the known ileal disease neuroendocrine tumor. I'd like to draw your attention to the tumor mitotic index of less than 2 and the Ki index of being low grade. If you look all the way down at the immunohistochemistry, the labeled box show the Ki 67 of less than 3%. So it's mostly in line with the previous lesion. Okay, how about the breast lesion now? So would you observe it, do mammogram and a biopsy? Of course, we've done a mammogram and a biopsy. So mammogram was done in 2020 in November, and that showed 3 small densities around 9 o'clock on the right side that needed further assessment by ultrasound and a biopsy that should be done properly. So here's the challenging part. So the breast biopsy showed tumor features that are suggestive of well-differentiated neuroendocrine neoplasm. Remember, that's a biopsy, it's not an FNA. So the breast tumor is most likely to present metastases from the ileal neuroendocrine tumor with a metastatic of less than 2. However, the Ki-67 index is quite high, would make it a grade 3. So there's a discrepancy between the liver metastatic disease, the breast lesion that is being identified, although it states very clearly here that it is metastatic disease from the endocrine tumor, and with the main difference of the Ki-67 being higher on the breast lesion than the liver lesion. Again, that's the difference that we already spoke about. However, keeping in mind the fact that the octreotide scan that she had did not light up for any other lesions outside of the one in the liver metastatic disease. So the octreotide scan that was done again in 2021 to assess how things had been, because she has been on the octreotide injections for a few months now, showed stable, faintly tracer avid liver lesions I described above. No extrahepatic octreotide avid lesions were seen. We had discussed her case multiple times actually in the tumor boards, and the case and the final decision in most of these studies were just do the biopsy. It turned out to be neuroendocrine tumor in the breast, then just carry out with the octreotide injection. But going over the case multiple times, another discussion basically was taken into account, with the main argument from my part was that the Ki-67 was still quite high in the breast, and it does not go along with the previous lesions that she had resected, or the one in the liver. And the fact that it did not light up on the octreotide scan would make the breast lesion quite suspicious. So the case was rediscussed again at that time, and it was referred back to surgery, where she had a simple lumpectomy along with sentinel lymph node biopsy ideally. So the final pathology of the breast lesion, on the left-hand side, as you can see here, it turned out to be mucinous breast carcinoma, as opposed to a neuroendocrine tumor. And more additionally, it was ER positive 9%, PR 33%, and HER2 was negative. So mucinous breast carcinoma would only represent 1 to 4% of all breast cancers. It does not readily spread basically to the lymph nodes, and it is felt to be a little bit small and slow-growing tumors as opposed to the well-known invasive toxic carcinoma. So basically, that's a case report where it showed the neuroendocrine differentiation that has been described in both in situ and infiltrating breast cancer, and most importantly, mucinous carcinoma of the breast appeared to have greatest association with neuroendocrine differentiation. So the report was re-amended later on, and it was shown to be mucinous breast carcinoma as opposed to neuroendocrine tumor. Definitely have to do the usual stuff. We sent for Oncotype DX and turned out to be 14. There's no benefit to chemotherapy, and she was not in line to go ahead with any chemotherapeutic agents. So now, after she had the surgery, we continued the Octreotide injections, and she has been on it for about 7-8 months. And she had excellent response, complete resolution of the clinical symptoms, almost complete normalization of the 24-hour 5-HIAA, and she was started on adjuvant letrozole along with vitamin D and calcium appropriately, and she received radiation therapy to the breast area where it was resected before. So another Octreotide scan was done in June 2021. Again, there is no extrahepatic Octreotide avid lesions, and there's the tracer avid uptake in the largest lesion in the segment 7. And there are no, and the previously seen lesions in segment 2 was not seen. So she had a good response to the Octreotide injections as well. So her case was rediscussed again, and we decided to carry out the Octreotide injection and not to stop it. And she was referred to surgery. From there on, the surgeon stated that there were a bit deeper lesions in the MRI, and they were concerned that they would not be amenable for any surgical intervention or manipulation. Hence, she was sent to IR, where they had assessed the patient, and they offered her IR-directed therapy through arterial embolization, and she had done that successfully without any major issues back a few weeks ago, and we're still currently waiting for the follow-up restaging that she has. She continues to be on Octreotide, and we're actually decreasing the frequency, and we're thinking of decreasing the doses as well, since she has complete resolution of her symptoms, and she had hopefully a curative intent approach in her liver lesions. She continues to be on letrozole as adjuvant therapy of breast cancer, and we're still looking for further genetic assessment, as she has significant family history of cancers, and now definitely she has 2 different primaries, which would put her at high risk with the main consideration of Lee-Frommel syndrome as being the greatest in her case. So the main take-home messages is basically, as you can see here, that the case was not as clear, and there was a lot of back and forth and discussions, but always consider biopsy of any root lesions, and not to assume it being part of a known primary that the patient had or has in the right context. Always consider a different primary based on the histopathological features, while paying close attention to other aspects in the pathology, such as KR67. And I think in her case, it was the KR67 that gave it away, along with the absence of any Octreotide scan avidity in the breast. And always remember to provide the patient with carcinoid syndrome prophylactic doses of Octreotide injections, IV, pre or during and post any surgical manipulation. With that, I conclude my presentation, and thank you very much for your kind attention.
Thank you, Dr. Ahmed, for a nice and illustrative case. Thank you to all the speakers for bringing very interesting and challenging cases. Now the floor is open for questions. We have few questions posted in the Q&A chat box. We will go over some of them. Question maybe to be addressed to Dr. Kannan. Do you need to send all net cases for NGS testing? Is there any potential genetic or molecular alteration that can be picked up in net cancer patient?
I'm sorry, I did not hear the question, Dr. Ahmed. Apologies.
Yeah, the question. Do you hear me now?
Yes, I do.
Do you hear me? Or so?
Yes, I do.
One question posted by one of our audience. asking the question about the role of NGS testing in neuroendocrine tumor. Is there any like druggable mutations that one can look for? Any idea?
Excellent. So I'm not aware of any druggable mutations in high-grade neuroendocrine carcinoma. And the case that I presented is a bit unique. Probably the reason I did not send for neuroendocrine carcinoma is because of his prognosis. And I did not really expect him to have a CR in liver. He's 80. He exceeded probably his normal life expectancy. Do I expect
Dr. Kannan, you have problem with the internet connection, I think. Dr. Kannan?
Are you able to hear me?
We cannot hear you well. I think you do have problem with the internet connection. Can you try to fix it?
Dr. Ali, can you hear me?
Yes, I can hear your voice. Yeah.
No, we can hear you.
طيب, thank you. So maybe the problem is maybe with your connection, Dr.
Maybe
Ahmed.
from my end, yeah.
طيب, so just answering this question very quickly, is there a role by evidence? No, there isn't. Would I do it if I had a younger patient with excellent performance status, just like the one that I presented? Yes, I would in the second line setting. I mean, it is costly. NGS is limited by cost. And we don't really have actionable mutations in high-grade neuroendocrine carcinoma. However, would this prevent me from doing it if I had a younger, fitter patient? I wouldn't. No, it would not prevent me.
Dr. Kannan, Ahmed Alleheibi, do you agree that Octreotide scan should be completely replaced, or it's obsolete now to be used in clinical practice and should be replaced with a bit gallium-68? Is it more sensitive modality of evaluating patient with neuroendocrine tumor?
So to be honest, I would leave this question to our nuclear medicine guys. I mean, in my case, Octreoscan has no role because it's a high-grade neuroendocrine carcinoma. It's not a low-grade or a well-differentiated net.
For low-grade tumor.
Huh? السؤال لأحمد. Oh, sorry, I apologize.
Ahmed Alleheibi, for well-differentiated neuroendocrine tumor, do you think it's time now to shift to gallium PET scan as staging modality?
No, so basically, thank you so much, Dr. Ahmed. And I wouldn't say actually more than what Kannan had mentioned, but definitely I would leave that question to our nuclear medicine people. However, keeping in mind that the gadolinium scan is not readily available. It is a bit more sensitive. It is quite specific actually in these cases, but the more available scanning that we have now is Octreotide. So I don't think it's going to change it, at least not at this point in time. So we always have to stick to Octreotide scan because it's readily available.
Another question, I think this has been addressed during the discussion today morning. Would you continue Octreotide post-disease progression, post-progressive disease, along with maybe other modality of treatment? Dr. Ahmed?
Oh, so sorry. Yeah, so when there's a progressive disease on patients who had already been on Octreotide injections, I definitely would stop and would switch to the subsequent line depending on the Octreotide scan results. If it was still avid and still positive, or they had a previously positive Octreotide scan, then would consider PPRT along with lutetium tatate. And then if that was not readily available, then it would go to the other lines, which are going to be a TKI, and depending on the original site of neuroendocrine tumor, then it would go for either everolimus or Sutent if it was pancreatic or small intestine. But yeah, I wouldn't continue with Octreotide on its own until I have some control, then would carry out with the Octreotide.
Okay,
I have a question or comment.
Go ahead, Dr. Abdurrahman.
Thank you for the excellent cases. My comment first to Dr. Ahmed. For your case that you presented with extensive family history of leukemia, sarcoma, and breast cancer now in this patient, What I would do differently, that I would do genetic testing earlier because of Slieff-Romani disease. That's maybe not radiation, maybe not the, the way to go, and discuss it with the radiation oncologist. Maybe that's the only thing, but it was excellent case. That's the comment. The question to Dr. Kannan, for your case, the neuroendocrine and hepatocellular carcinoma for the second line. We know there is some trials for Topotecan for the second line, and that will be used for small cell and can be for HCC. What do you think about that?
Thank you, Dr. Abdul Rahim. Probably that's an option. With neuroendocrine carcinoma, high grade, would I actually think about giving him something even more aggressive like CAV? Performance status 0. He is 80. So it really depends on his clinical condition at progression. He does have a complete response now in the liver. Is it going to be long-standing? I don't think so. He is getting consolidative treatment to his consolidative radiotherapy to his lung. How long is this going to last, and how long is his clinical condition going to be good for, is what is going to dictate what second line I'm going to give. Thank you.
Thank you. Let's go back to the question from virtual attendees. One question here: who is the best NET patient or candidate for TKI? Maybe at the time of progression, do you have any clinical feature or molecular biomarker to select TKI over BRRT, for instance? Dr. Ahmed Alleheibi, is there any clinical features that would dictate the choice of treatment?
So basically, the main feature is basically the original pathology or the original disease site. So if it was pancreatic or it was small intestine, it's gonna be different options in terms of maybe third line. But everolimus can be applied to all, and suited would be made to pancreatic and small intestine, should they progress on the octreotide. But always keeping in mind the octreotide scans, whether or not it's been avid or not, because if it's still with avid, then you would apply the lutetium dotate mainly with the small intestine neuroendocrine tumor if they progress in subsequent lines.
Okay, I have a question to Dr. Ali Al-Faqih. Since your patient has locally advanced disease at presentation, which is really common presentation of biliary cancer, as you can see, ABC 02 study, around a third of patients have locally advanced disease. My question to you, because you are aiming at down staging and potential cure, your endpoint is R0 resection. Would you have considered triplet chemotherapy in this case, building on ABC 02? Today we have data on GemCis plus cisplatin, or maybe GemCis plus nab-paclitaxel, or maybe FOLFIRINOX. We have data to show that triplet chemotherapy has a higher response rate, which may translate into a higher resectability rate. What's your take on this?
Thank you, Dr. Ahmed, for the excellent question. So for locally advanced or advanced biliary tract cancer, so the standard of care is actually GemCis. There is a response rate of 25%. With regard to triplet regimen, at this point, I don't think we have good evidence like phase 3 trial to support triplet regimen in advanced biliary tract cancer. But I agree with you, if the patient is very fit and will take the risk, because as you know, triplet regimen is associated with significant risk of toxicity, and this patient may end up with the severe toxicity that will preclude surgical resection in the future. So in this case, we gave this patient 4 cycles of chemotherapy. We are not aiming to give her additional chemotherapy to avoid toxicity to the liver, which will cause problem during surgery. But for the triplet regimen, I don't think at this point is recommended for all patients, maybe for selected patients, if we agree.
Okay, in the line of the same case, I really wonder if you would consider switching to adjuvant capecitabine post-resection.
That's a really excellent question.
Because, you know,
So,
gem oxaliplatin failed to show survival advantage survival advantage.
that's very excellent question. If the case is upfront resected without chemotherapy, then yes, I agree with you. Capecitabine is the best option at this point after the BELCAP publication. However, this patient has received what we consider preoperative or neoadjuvant therapy. And one of the objective of neoadjuvant therapy is to test the biology of the tumor to the chemotherapy that was given. And this patient actually, she responded very well to the chemotherapy evidenced by radiology and pathology, given that she has a very advanced disease at the beginning, invading multiple organs. At the end, it was only limited to the gallbladder and liver. So it was felt that continuing the same regimen that she responded, if in case she has not responded to the treatment, or she has very large residual, multiple lymph nodes, multiple organ involvement, then yes, I may consider capecitabine or even chemoradiation.
That's fair answer. There's a question because, you know, most of our audience are from MOH, Ministry of Health Hospital. There's a question regarding access to NGS testing for cholangiocarcinoma cases. What's your advice, Dr. Ali? When do you think a patient with cholangiocarcinoma be referred to a tertiary hospital where you can have NGS available for patients?
So that's an excellent question. NGS is actually, even in tertiary care centers, are not readily available. So it's most of the time we request it from the pathologist case by case. In case of cholangiocarcinoma or biliary tract cancer, as was discussed in the morning, most of the approved targeted agents are in the second line. So if the patient received first line and he responded, then progressed, still he has excellent performance status, the patient is fit and young, then yes, I will consider NGS looking for targetable mutation. However, most of the patients with the advanced biliary cancer, once they progressed on the first line, actually they have rapid deterioration in their functional status with poor functional status that preclude their further line of treatment. So if the patient still fit and young and the test can be done, either sent out or to other centers to do it, then yes, we can request it and look for targetable mutation. So the most common targetable mutation are in intrahepatic cholangiocarcinoma. We have FGFR2 and IDH1 and 2, while in gallbladder we have the HER2 test. MSI is percentage is low in overall cases, but if it is positive, then it's a good candidate for immunotherapy.
Dr. Ahmed, if I may ask, Dr. Zahrani, do you actually do it?
Go ahead.
Do you do it routinely in all of your cholangiocarcinoma cases, the advanced ones that need systemic therapy?
You know, in practice, I think it should be done upfront for all intrahepatic cholangiocarcinoma patient, where it's very rich in, you know, such molecular alterations. So I think it should be done for all intrahepatic cholangiocarcinoma patient upfront.
Yes.
And accordingly, you treat your patient. So NGS is standard of care.
I agree. I agree. I fully agree. And I think one of the caveats with Dr. Ali Al-Faqih's approach is doing it at second line is that NGS actually takes time. And sometimes the pathologist, once if they take it from a biopsy, there isn't sometimes enough tissue to actually do the full testing. So you may actually end up, or the pathologist may require you to do a second biopsy, which takes time to plan, and the NGS send-out test will take time to come back. And I think this is time that will be lost from the patient's therapy. So I agree with Dr. Zahrani's approach, is probably doing it upfront in your intrahepatics if their performance status is excellent, and you do anticipate that they will have a decent performance status at progression. And sometimes predicting those patients is actually quite difficult.
Yeah, I agree with you. I thought the question was for Ministry of Health institutions. Okay. But if the test is readily available in the center, yes, I totally agree with you. Doing upfront NGS for all cases of intrahepatic cholangiocarcinoma and requesting a specific test for special cases like young agent, multiple family history of involvement, and high risk of also MSI high cases. But in the MOH, I think it will be difficult. I'm not sure if they have access as a first line, but this can be considered in second line also.
Another question posted by one of our attendees, that to be addressed to Dr. Ahmed Alleheibi. Do you think 5-HIAA should be done routinely during follow-up, during surveillance?
Yeah.
Is it part of the surveillance program?
Yeah. I think especially for cases where they have positive carcinoid syndrome, like upfront, with elevated 5-HIAA upfront, they should be followed up every time that you see them and just see how they trend down. It should not tell you about you should stop the treatment or not, even if they were not changes, but erogenous in the test itself, because the patient has to avoid a lot of food and a lot of other categories and the fruits and whatnot that can actually make the test a little bit erogenous. So it is something that you would do, but not you would rely on a lot in your clinical practice. So you have to interpret the results with extreme caution.
Okay. You have really done, you have elegant presentation. My question to you, would you think you added atezolizumab with the first line therapy? What about if you start just tackling the most aggressive biology, which is neuroendocrine tumor, and then reevaluate the status? You do CT scan like 2 months, and then you see what the things are at, and then accordingly you plan your subsequent therapy. So what's your thought about this? Because atezo is an expensive drug, you might not have an access to atezolizumab. So what's your thought about this?
So that's a great thought, Dr. Ahmed. And I think one of the thoughts that I presented in the review article from the expert oncologist group is that the sequencing approach. So they would treat the most aggressive tumor for a few cycles, then they would cycle by treating the less aggressive tumor for a few other cycles, and so forth. But in our case, the reason I chose atezo upfront is that because it has some activity against small cell lung cancer, realizing that this is not small cell lung cancer, but it does behave like small cell lung cancer. And atezolizumab does have some effect against hepatoma. And in our case, it did not respond in terms of the HCC component not responding. And I think we were lucky enough to salvage the patient with ramucirumab, having had a good response. Now, it's actually quite difficult to actually delineate whether the response was from the tear, because he had 2 tear procedures, or whether it was from the addition of ramucirumab, or it's a mixture of both approaches. And I do think with a high alpha-fetoprotein, we know that anti-VEGF or VEGF inhibition does work. And hence, I do believe that ramucirumab probably had a beneficial effect in that case.
Yeah, maybe one last question to Dr. Ali Al-Faqih. Is there any approach to, clot skin tumor without biopsy? as we face many cases that are difficult to biopsy, would you consider treating, patient based on CT scan finding or MRI finding, or you think it's a must to do biopsy?
Thank you for the question. That's really challenging because, as you know, classical tumor most of the time are unresectable. The other name is hilar cholangiocarcinoma. The best treatment option for those kind of patients are actually from retrospective data from, I think, Mayo Clinic or Memorial Sloan Kettering, where they included those patients for liver transplant. But for the biopsy, I think there are many ways to get a pathology. Not only biopsy, we can also ask for FNA or even brush cytology from the ERCP, which in case it showed any evidence of malignant cell, then chemotherapy can be started. But I don't think any oncologist or any radiation oncologist would start any oncologic treatment without evidence of malignant cell, at least in the pathology. In some cases, if there are multiple attempts, multiple biopsies, multiple procedures, maybe at the end, maybe surgical exploration is the last resort. Yeah,
it's essential to obtain tissue diagnosis for the, to establish the diagnosis, and also to do molecular profiling for patient if needed. Any more question, Dr. Kannan?
No, not from my side. I'm not sure if Ahmed have any final questions or comments.
Probably, maybe one final question to Dr. Ahmed.
Any comment, any suggestion, any thought?
What do you think, Dr. Ahmed, about intermediate grade neuroendocrine tumor? Will you consider combination treatment from the start, like starting targeted therapy from the beginning, given that those cases, intermediate grade, they usually progress more rapidly than low grade? What do you think?
No.
Yeah, go ahead, Dr. Ahmed Alleheibi, go ahead.
Sorry, so Dr. Ahmed, which one? Yeah, Dr. Ali, Dr. Ahmed Alleheibi, sorry. There are two Dr. Ahmeds.
Yeah, Dr. Ahmed Alleheibi, sorry.
Sorry, Dr. Zarani. So no, I think that's a very challenging question, to be honest. It all boils down to the main presentation the patients come in with. Do they have carcinoid syndrome or not? Do we have to worry about the heart or not? Definitely it all comes down that should they have any symptoms of carcinoid syndrome, then you have to start octreotide scan to control that. Otherwise, these symptoms will not go away on its own, even if you added in any other treatment options. And when we talk about the intermediate group, again, there are certain circumstances where you just can go ahead with upfront chemotherapy if you think that they would respond the best to them, and that can be established in certain cases of pancreatic cancers. I wouldn't go ahead with that upfront until I control their diseases first with octreotide. I can go ahead and give them PPRT if they have a readily available or avid disease based on the octreotide scans. And basically, if I see that there is any progression, any evidence of progression within a short period of time, then I would not hesitate in just going ahead with giving them everolimus or Sudan based on the primary site of disease, while keeping the octreotide because they had octreotide syndrome at the beginning. So that would be my approach in these cases.
Yeah, if no more question, thank you very much to all the speakers for their elegant presentation. Thank you to all attendees for their excellent questions and interaction. By this, we can conclude the session. The mic is yours, Dr. Kannan.
Thank you, Dr. Ahmed, for great moderation and leading the discussion as always. Dr. Ahmed Alleheibi, Dr. Ali Al-Faqih for the great presentations, and myself, of course. And I also thank Dr. Ashwaq for co-chairing this meeting. I'd like to thank all the online attendees for joining us for this liver and pancreatobiliary masterclass. I'd also like to end this by thanking our sponsors for their generous sponsorship and making this meeting happen. And by this, I thank you all and conclude, and I wish you a great rest of your day. Thank you, everyone.
Thank you.
Thank you.
يلا حياكم الله.